Hello and welcome back to CCRN Review, Cardiovascular, Part 3. In this section, we're going to talk a little bit here about cardiomyopathies. So this is the end result of many of our cardiac diseases. The patient ends up developing a cardiomyopathy. What happens in a cardiomyopathy is that the heart muscle changes its size and shape. So the size and shape of the heart muscle changes, which then makes the muscle ineffective. Now, when you look at the heart, it's got that kind of weird V shape to it, right? It's not round like this one here that you see in the picture. The one we see in the picture here is a patient who has some really severe dilated cardiomyopathy. We need to have that V shape in order to be able to have a good, strong contraction. When the heart muscle starts to balloon out like this, in this big round shape that we see here, now we no longer have a really effective myocardium. So we're not getting a strong contraction. And in fact, in this case here, this patient probably has some really severe and advanced heart failure as a result of this heart being so big and round. It no longer has a very effective contraction. So what causes a patient to develop a cardiomyopathy? Well, a main cause would be a progressive decrease in cardiac output. So the things we talked about previously. We talked about having myocardial disease and acute coronary syndromes and how they decrease the perfusion to the heart, which then decreases cardiac output. Okay, so that is one thing that's going to cause our patient to develop a cardiomyopathy. Persistent or chronic tachycardia is going to make the myocardium hypertrophy, and as that myocardium hypertrophies, it can change shape and become less effective. Hypotension. These are some of the symptoms we may see, is hypotension, diaphoresis, pallor, a backup of fluid backing up into the periphery. So let's take a look at these different types of cardiomyopathy. On the top left, you see the normal heart. And again, see that V shape that we get there to the myocardium, to the left ventricle rather. We want to have that V shape in the left ventricle so that we're having a nice, strong contraction. On the upper right, we have the patient who has a dilated cardiomyopathy. And in a dilated cardiomyopathy, we have this rounded-looking ventricle. And again, that's not going to pump very effectively, so we're going to start to see some symptoms of decreased cardiac output. Down in the lower left, we see the hypertrophic myocardium. This can be idiopathic, so just a idiopathic thickening of the myocardium. In many cases, it's going to be the hypertrophy that we associate with either chronic tachycardia or with parts of the heart becoming injured. So we have a little MI somewhere, and there's a part of the heart that is not pumping as effectively as it should be, so the rest of the heart starts to hypertrophy. There may be a possibly genetic component here too that causes hypertrophic cardiomyopathy. One of the main problems that we see here is we have that septal thickening. So look at the septum in this one with the hypertrophic cardiomyopathy. You notice how that septum is thickened, which will decrease our cardiac output and cause dysrhythmias. Our treatment is going to be a surgical thinning of the septum. So they would go in and actually thin out the septum so the muscle isn't that thick, isn't that big. Or they may use a ablation of the septum to try to decrease the size of the septum. Over on the bottom right, we have restrictive cardiomyopathy. This is oftentimes caused by diastolic dysfunction. Remember again, systolic dysfunction is decreased contractility. Diastolic dysfunction is decreased relaxation. So whatever it is that's causing this decreased relaxation is resulting in having a restrictive cardiomyopathy. So the myocardium is not relaxing fully for whatever reason, and that's resulting in the patient ending up having this restrictive cardiomyopathy. The ventricle becomes stiff, usually or oftentimes from fibrotic tissue. So it may be a situation where we have sarcoidosis or a situation like that that's causing some kind of a fibrotic event to occur in the septum and making it less elastic and less able to relax so that we can have a good filling and then a good contraction. The treatment's beta blockers, and there really is no, because again, when we're talking about fibrotic tissue in the myocardium, there's really no good way to be able to treat that. So these patients would end up probably needing to have a transplant. So as you take a look at this illustration here, this is an x-ray of a patient who has cardiomyopathy. You see that big, huge heart. See how huge that thing is? So one of the reasons why I'm showing you this is not just to get an image of what a big heart would look like in a patient who has a dilated cardiomyopathy, but also to understand how much this is going to impact other organs. So take a look at that left lung. How much of that left lung do you think is working, especially in the bases in the back? We probably do not have good filling of this lung, and we probably do not have good aeration. Remember that the bases are the area of the lung where we have the best perfusion, and so therefore we have the best gas exchange occurring in the bases. So we've effectively cut out the left base in this lung here in this patient. So the patient's kind of running on one lung in addition to having decreased cardiac output. The next condition we're going to take a look at here is hypertensive crisis. A hypertensive crisis is defined as having a diastolic, blood pressure above 120 millimeters of mercury acutely. Okay, so we consider that to be a hypertensive crisis. Some people will develop high blood pressures over a period of time, and they'll come into the emergency department and they'll have a significantly high blood pressure, especially those patients who maybe have some neurological dysfunction or neurologic conditions. And what they're trying to do is they're trying to perfuse their brain. So we have to take into consideration what all is going on with this patient. So let's move on down to those etiologies to find out why this patient is having a hypertensive crisis at this time. Oftentimes, our patients who have hypertensive crisis have some kind of pre-existing hypertension. That's a very common underlying problem with patients with hypertensive crisis. It may also have some component of renal disease or scleroderma. There may be some other underlying conditions that are occurring here, but we look for that underlying or pre-existing hypertension as being a primary cause. Now, the patient may not have any history of any of these diseases if they've had a head injury or there's some other acute injury that's occurring. The symptoms we'd expect to see is chest pain. Okay, we're making that heart work awfully hard by having that very high blood pressure. We may expect to see a headache. Okay, the brain's saying, whoa, we got way too much pressure up here, don't need all this stuff. Decreased mental status, diuresis, all that blood pressure going down to the kidney. Kidney doesn't need all that pressure. It thinks when the blood pressure is very high like that we have too much fluid on board, so it's going to start to try and dump off fluid. So this patient may actually end up being hypovolemic. Diagnostically, we want to get some electrolytes and so on. We want to find out what's going on here with this patient to see if there's some kind of underlying issue that we need to treat as well, assuming that this is probably kind of an out-of-control blood pressure situation, but it could also have some other components involved with it. Remember, renal dysfunction, etc. So our treatment is going to be sodium nitroprusside. We're not going to mess around with trying to get this blood pressure down. We're going to try and get it down ASAP. With sodium nitroprusside, we don't want to just dump that pressure down. We don't want to go from 240 over 120 down to 100 over 70. We don't want to do that. That could cause some real serious problems in the brain. So we have all this pressure up there in the brain. Suddenly we drop the pressure. Where's the fluid going to go? It's going to get sucked all into the brain, isn't it? So we're going to have problems with fluid movement if we're having a very acute sudden change in the pressure. So we want to start to reduce this blood pressure a little bit at a time. A third of the reduction in 6 hours, another third in the next 24, and the last third over maybe 2 to 4 days. So a slow decrease in the patient's blood pressure, not a huge drop. So let's get it out of the real danger zone. Maybe get them down to like 200 over 100. Let's get them out of that real danger zone. And then we can slowly move him out of that hypertensive area. Hydralazine, enalapril, beta blockers, those might also be used. Those medications are going to take time to work. So if we have a real crisis situation, we're going to run right to sodium nitroprusside because it'll be working almost immediately. Some complications include myocardial infarction, heart failure. And remember that blood pressure and tachycardia, those are possible etiologies for heart failure. Stroke, cerebral bleeds, aortic dissection. Okay, those are all possible complications as a result of having this hypertensive crisis. Another test-taking tip that you'll notice in your handout there is to study. All right, you knew this was coming, didn't you? Yeah, in order to pass the CCRN, you are going to need to study. That's what you're doing right now. So you're doing some studying here. We're working on studying. We also need to do some additional study. And hopefully with this program, you'll have some very clear ideas as to what you need to study, when you need to study, and how much. As an initial hint, I'll tell you that start looking at the areas that are your weak areas as we go through. As we start working through this content, and I'll tell you how to identify your weak areas. The weak areas are the areas that you probably don't like. How many people want to run out there and start studying endocrine? Ugh, right? And how many people want to jump out and say, hey, I want to go study endocrine? It's one of those areas that people are uncomfortable with, and so therefore we don't like it. The areas that we are comfortable with and we do like are areas that you probably don't need to study. So if you're a cardiac nurse and you're digging this cardiac stuff, this is probably not something you need to study. Go through and watch the videos, but then after that, move on to something that you need to study and work on those areas. Because I guarantee you, you're going to get to that exam and you're going to find out that they're going to ask you a question about that weak area. And that's what I hear from almost everybody that takes the exam, is they come back and they say, well, they asked lots of questions about this weak area. Okay, well, it's not lots of questions. It's just the questions were the ones you paid attention to, and they felt like a lot because you didn't know the answers. So we need to study. Let's talk a little bit about cardiogenic shock. So the end complication that can occur with all of these cardiac problems is the patient may have a pump that is no longer working, and the patient develops cardiogenic shock. We can anticipate cardiogenic shock in our patients who have myocardial infarctions. And as a complication of myocardial infarction, anticipate cardiogenic shock and be looking for it. So when your patient has an MI or your patient has some kind of cardiac disease and they have an acute problem as associated with that cardiac disease, be looking for the signs of cardiogenic shock, and then you're not going to be surprised when it starts to occur. The key to taking care of patients in cardiogenic shock is to plug in the pump. We plug in the pump by giving the patient supplemental oxygen, slowing the heart down, and decreasing stretch. All right, well, how do we do that? Let's talk about that a little bit. Supplemental oxygen, obviously, in where there's some debate about whether or not that's necessary. So you want to be looking at your patient's SpO2. Slow the heart down. The faster the heart beats, the more oxygen it's using. And decrease stretch. What's causing stretch in the heart? Venous return. The more venous return we have coming back to the heart, the more we're stretching the heart, and the harder the heart's going to contract. You remember hearing about that before? That's called Starling's Law of the Heart. You remember hearing that? Somewhere along the line? The more you stretch it, the harder it contracts. The harder it contracts, the more oxygen it uses. So we don't want to do that. So we're going to try and decrease stretch, which means keeping that blood away from the heart. We don't want lots and lots of blood coming back to the heart. The heart can't pump what it already has. Think about the heart like an IV pump. If the IV pump were beeping and telling you that you had a low battery, would you turn up the rate on the pump? See, that sounds silly when we're talking about an IV pump, yet we do that all the time with our patients in cardiogenic shock. The patient has a low blood pressure, so the first thing we do is we give them a positive inotrope. Okay, well, that's going to tell the heart to beat harder. It would if it could, right? So we need to plug in the pump before you tell it to work harder. And you plug it in by slowing the heart down, decreasing stretch, and maybe giving supplemental oxygen. Okay, so you have this diagram in your handout here, and what it's illustrating, let's start in the middle and let's work our way around. So let's start on the left side, in the middle, so with myocardial dysfunction, that's where I'm starting. And I'm going to work my way around. So we have myocardial dysfunction, which results in decreased cardiac output, which causes hypotension, decreased coronary perfusion. Now, let me just back up there for a moment. Decreased cardiac output means we're not pumping as much blood, which is going to cause hypotension. That seems to be pretty straightforward, but let's go on to the next one. Decreased coronary perfusion. If cardiac output is low, that means the cardiac output to the heart itself will be low too. So we'll have decreased coronary perfusion, which then causes more ischemia, more myocardial dysfunction, and you see how that cycle on the left side keeps going. More decreased cardiac output, more hypotension, more decreases in coronary perfusion, more ischemia, on and on and on. Now, let's go over to the right side, and that myocardial dysfunction is causing an increase in left ventricular end diastolic pressure, which causes pulmonary congestion, hypoxemia, ischemia, and further decreases in myocardial dysfunction. So we have these two systems that are going on, these two mechanisms of decompensation that are occurring in your patient who is having myocardial dysfunction. Oftentimes what we will do to try to correct this is that we will try to attack the cardiac output. So we go right to the decreased cardiac output and we give a positive inotrope. We haven't fixed the problem. And if we start telling the heart to beat harder and faster when we're not getting it enough oxygen, we're going to run away from our oxygen supply. Now, it is true. Go over to the left side again. If you increase cardiac output with a positive inotrope, you will increase coronary perfusion. You will increase oxygen to the myocardium somewhat, not enough to overcome the increase in oxygen demand. So we need to be looking at how we're going to plug in the pump. Treat the ischemia pieces first. So we have hypoxemia, we have ischemia. Let's treat those. We can treat the increase in left ventricular end diastolic pressure by decreasing some of the fluid that is coming back to the heart. Cause venous vasodilation, pull the fluid out into the periphery, and now it's not coming back to the heart, so it's not overwhelming the heart as much. So when you look at the treatments that we use in cardiogenic shock, some of them don't make a lot of sense. If we have a patient who has decreased cardiac output and they're in cardiogenic shock and somebody says, give the patient nitroglycerin. Okay, remember one of the problems here is hypotension. And somebody says, give the patient nitroglycerin, you might say, are you kidding me? We already have hypotension. But what happens is, by causing coronary vasodilation, we increase the blood supply to the coronary arteries, which increases oxygen supply to the coronary arteries, decreasing the ischemia to the myocardium, which will increase cardiac output. So don't be surprised if you get an order like that. So the presentation in a patient who is in cardiogenic shock, we'd expect to see hypotension, tachycardia. Again, we have decreased cardiac output. And narrow pulse pressure. Pulse pressure is the difference between systolic and diastolic. We expect to see that the systolic and diastolic start to become kind of close. If you think about a normal blood pressure, what we consider to be normal, 110/70 or 120/80, whatever the case may be, you notice that the difference there is about 40 millimeters of mercury between the 110 and the 80, or I'm sorry, 110 and the 70 or 120/80. There's about a 40 millimeter mercury difference between those. In a patient who has cardiogenic shock, we may see a blood pressure like 80/60. See how that's narrowed? Now there's only a 20 millimeter difference. We also expect to see fluid volume overload, which will result in a positive INO, increased weight, pulmonary edema, and jugular venous distension, which we talked about earlier about how to assess. So again, our treatment is we're going to use those medications that are going to plug in the pump. Now again, we may still use medications like dobutamine, maybe some norepinephrine, etc., but we're going to plug in the pump if we can first. Morphine, believe it or not, is a coronary vasodilator, so it helps to increase the amount of oxygen that gets to the myocardium. It will also decrease our sympathetic nervous system response, which decreases heart rate and our oxygen consumption. The main thing, though, is we need to treat the underlying cause. Treat the MI. Treat whatever it is that's causing this patient to have cardiogenic shock. One of the treatments that's used is an intra-aortic balloon pump. They will ask you about intra-aortic balloon pumps on the exam. They don't ask you how to time them or how to insert them, those kind of things, but they do ask you why one might be used. An intra-aortic balloon pump, as the illustration here shows, it goes up into the aorta, the descending aorta here, and it sits there in the descending aorta. Once the patient's heart contracts, so we have systole, then the balloon will inflate. There are a few functions that will occur as a result of inflating that balloon. One is it pushes blood out of the aorta, pushes it up, going up to the brain, pushes it down, going to the rest of the systemic circulation, and pushes it backwards. Pushes it back toward the heart, because remember, the coronary veins, coronary vessels rather, are going to originate right from the base of the aorta. So the coronary vessels originate from the base of the aorta, and if we push blood back toward them, we will increase the pressure in the coronary vessels, thereby increasing myocardial oxygenation and hopefully improving cardiac output. These things work so well that we're going to have to slowly decrease the use of a balloon pump in most cases. So maybe we start out by having the balloon inflate with every contraction, and then maybe every other, every third contraction, etc., so that we can kind of wean the patient from the balloon pump because they work so well at improving cardiac output. Revascularization, obviously, if this is secondary to myocardial infarction.